the first session, which is Associate Professor Margaret Rogers. Where are you, Margaret? From University Hospital Geelong and Barwon Health, who is presenting a feasibility study for screening of diabetes in oral health settings. Welcome.
Thank you. This has been a collaborative project. We're lucky at Oral Health to have a small research team. We also have the clinical team and the management team supported by Dr. Michael Smith. We've had the expertise of Professor Tricia Dunning and from Marg White from Colac Area Health. And I've hit the slide the wrong way. Just use the arrows. For those that don't know the oral health services at Barwon Health, we're actually situated at Newcombe, Belmont, Corio and Colac. We provide dental care to eligible healthcare card and pension card holders and their dependents. So we have a large clientele of disadvantaged people. For this project, the inspiration was that we start to screen diabetes in the community dental clinic. Colac alone has an eligible population of nearly 18,000 people that can attend the Colac Dental Clinic. That in itself surprised me. The individuals that came to the clinic over 2 years was 5,300, and that's new individuals, that's not just visits. A lot of these patients actually come for repeat visits, so it's nearly 8,000 visits in 2 years. The number of decayed, missing or filled teeth in these patients, I've got greater than 14. Imagine 14 in your teeth that are either decayed, missing or filled. That's just the starting average for patients from about 20 to 45. It then went up with the age groups. So we've got patients coming with disadvantaged backgrounds, needing a lot of dental work. The inspiration for this project has been the link. It's 99.9% of the time it's Dr. Michael Smith's idea, and this was another one of his ideas, is that diabetes and oral health problems are very much linked. Periodontal disease, number of decayed, missing or filled teeth. So Michael's thought, okay, it's time to see if we can screen for diabetes in the community dental clinics. So our aim was to determine the feasibility of such screening. We would like to inspire a change in community and health service attitude towards diabetes testing in the community dental clinic setting, and design and implement appropriate referral pathways from the community dental clinic to the diabetes educator or to the general practitioner. The methods for the study, the patients come in, they'll see the dentist or the prosthesist or the oral health therapist. The plan was they'd be examined, they'd have a measure of their periodontal disease, which is the CPI index, the number of decayed, missing or filled teeth recorded. A treatment plan will be decided upon. At that stage, they'd be asked whether they'd be willing to participate in the diabetes screening. Those that said yes completed an Australian diabetes risk assessment tool. Data entered into an access database which we designed. We've got Titanium with oral health, but we've also designed the database that links for all of this study. For those that scored greater than 6 with the diabetes assessment tool, they were then offered a HbA1c blood test at the point of care. This is actually the biggest part of the study. There's the research, but the biggest part is getting in and making the change at the point of care, which I know 99% of people here will understand. All staff were trained in the HbA1c testing. The staff were a little bit reluctant, sorry, I shouldn't say a little bit, the staff were reluctant to bring in a change of care. Where to fit in the diabetes questions and the testing into the schedule. Every patient that comes in, they come in different pathways. Some will come in to see the oral health therapists, some will be seeing the dentists, and there's all different pathways. So where to introduce it to make sure that every patient's screened. And also simply the pattern of dentists, their total attention is on oral health, and all of a sudden they've got this different screening. So introducing that was a skill in itself. It took many visits and many meetings, and Michael's laughing, it took many. Then at that stage, patients might come in for general admission, they might come in for emergency appointments. The response was, okay, how do we manage to fit in diabetes screening if they're emergency appointments? The thing is that they might be the actual ones that need the diabetes screening. So again, it was changing the attitudes and the patterns. The recording of data, again, at what point did it go into the database? And the other interesting thing with the community dental clinics, we have relieving staff from Newcomb, Corio and Belmont coming to Colac. So all of a sudden you have that new staff member coming in. So we had all those interesting things to work through. Patients and staff became accepting over time. I think resilience is a fabulous word. Dental assistants with Certificate 4 in dental assisting, oral health promotion and radiography were responsible for the screening. What we found out was that we managed to approach 309 participants over the last few months. Those that declined, there was only 41 that declined. The interesting part is because they become back for repeat visits often, we found some of those that declined at the start, they didn't decline the next time. They just needed to get used to it. 14% of these patients actually already had been diagnosed with diabetes or by their general practitioner, and 22% were currently being tested or monitored by their general practitioner. So we already have 36% already have some sign of diabetes. 171 patients filled out the Oz risk assessment tool. There were 15% in the low risk, 31% in the intermediate risk and 53% in the high risk. 46% of females and 78% of males. 146 patients accepted the HbA1c testing. In the normal range was 142 and in the high range was 4. But 2 in 3 patients presenting to the community dental clinics had either 1, previously confirmed diabetes, were being tested by their general practitioner for diabetes, or were in the high risk category according to the Oz risk assessment tool. Phase 2 of this study, we've sort of set up the screening. We now want to move towards the referral process, which we know again, it'll be the changes in care that will take the time. The other thing that might end up being interesting once we get confirmed diabetes is whether there's any value in including a measure of oral health care in the Oz risk assessment tool. Just lastly, I'd like to acknowledge the Collier Charitable Fund for the HbA1c analyzers, the Colac Dental staff for their patience, and the Colac Dental Clinic patients for accepting a new model of care.
Thank you, Margaret. That was really, I found that really interesting, fascinating and innovative, and I think as you identified, the most interesting aspect is that cultural shift for both staff and for clients and patients.